Peripheral smear interpretation. This is one of the exercises for second MBBS practical examination, and today we're going to talk about that. Now, peripheral smear is a smear which is prepared from peripheral venous blood or capillary blood, and once we collect the blood, what we do is we add one drop to a slide, and after we add a drop to the slide, we take another slide and we try to spread this. So we have spread and now we got a very nice smear. The reason why we do this smear is we want to study the morphology of the blood cells, whether they are RBC, WBC or platelets. Now before we try to study these things, which is RBC, WBC and platelets, we have to stain the smear so that when we look under the microscope, we can see the different morphologies of all these cells. So are we ready to stain? So stain coming up in 3, 2, 1, here it is. Well, all the Tide ads that I've watched, the Tide was going from left of the screen to the right of the screen. So I thought I'll just reverse that because Tide removes the stain and now it is reversing so that it is actually producing the stain. Maybe I should call it untied or something. Anyway, we'll move forward. So this is the smear after it is stained. And do you remember, like in your first year, what stain we used for peripheral smear? And the answer is Leishman stain. So even though in second year you are not required to stain the slide itself, now we have to actually know a few things about the stain because maybe the examiner sometimes will like to ask you about all the different types of properties that the Leishman stain have. Now Leishman stain has few things inside it. It has two major stains, and these stains are, number one is methylene blue and number two is eosin. So blue and pink, similar to what we have in HND in histology, whereas here it is methylene blue and eosin. And these, along with these, there is also one more thing called as methyl alcohol, and methyl alcohol acts as a fixative. Now, if someone asks you what is a fixative, the function of a fixative is to preserve the morphology of cells. In your first year, you might remember the term formalin fixation, because formalin stores organs, etc. It will not let them decompose, etc. In the same way here in the blood, for us to preserve the morphology, we have to use a fixative, and that fixative here is methyl alcohol. Now once we stain it, we see a lot of different types of cells. So you see RBC, which are these cells, you also see WBC, which are nucleated, and then you also have little tiny dots like this, and these are the platelets that we find. Now we see a different shades of blue and pink. The good thing about this Leishman stain is even though it only has two stains, which is methylene blue and eosin, but still here we can see different things. So this is red, this is pink, and there are different areas and different shades of blue and pink, and that is the advantage of using the Leishman stain. Now it is also great to differentiate between RBC and different types of WBC and platelets as well. And sometimes this question is being asked by the examiners and they'll ask you, what is a Romanovsky stain? So Romanovsky stain is named after a Russian physician whose name was Romanovsky, and he actually was the one who tried to prepare this new types of staining wherein he would use a fixative and these two different stains, and based on that you would get different shades of blue and pink. Apart from Leishman stain, there are also many different types of Romanovsky stains, and these are Wright stain, Giemsa stain and field stain. So I think you've heard of Giemsa stain, especially in the charts when we study about G banding, etc. But you also need to remember a few other stains such as Wright stain and field stain. And Romanovsky stains, not only for just studying the morphology of RBC, WBC and platelets, they're also very important for studying the morphology of parasites. For example, there are some hemoparasites, for example, malaria, and for this malaria, these stains work very well. We can clearly see the morphology of malaria, which is a hemoparasite. And once again here, so what are these cells which don't have any nuclei? These are the RBC, and now we have the WBC here. I'll talk about the different types of WBC just in a while, and we also have this thing which is the platelet. So now the examiners also want to know that what are the parts of the smear. So the smear, we put a drop here and we have spread it. So there are some parts to the smear. We'll try to go through the parts. So number one is the area which is closer to the area which we have put the drop is called as the head of the smear, and then further away is the body, and eventually the last, the much more farther away, is called as the tail. You have head, body and tail. Now people would love to ask you, what is the best place for you to study the morphology of cells? Now let's think about this and let's try to understand how this works. Now at the head, that is where we have put the drop, right? So when we put the drop, this area, do you think is more dense or less dense? So if you're thinking it is more dense, then you're right. The area where the head, near the head, is actually very dense, and there are a lot of blood film which is overlapping on each other, and as a result what happens is all the RBC around the head, they're all clumped together, they're all clustered together. So can you really study the morphology of individual RBC? Not exactly. So what we do is, as we go further up from head to the body and to the tail side, the RBCs start to spread properly, and we'll come to a point wherein the RBCs are touching each other but they're not really overlapping each other, and that is where is the best site to study the morphology of cells, and this site usually exists at the junction between body and tail. Now you might also ask what happens as we go more and more towards the tail. As we go more and more towards the tail, what happens is that cells are too sparse, and also there are some distortions, and that is the reason why we don't study the morphology at the tail. So the best place once again to study the morphology is the junction between body and tail. Now, as we can see here, now at the head side, you see a lot of cells which are clumping, which are on top of each other. So when you see something like this, don't panic. You can just go towards the body and towards the tail, and eventually you will find cells which are not really overlapping and they are spaced apart from each other. So one more tip during the exam is that when you focus, you all know that you have to study hematology at 100x. So it doesn't mean that you have to just start with 100x, because as you can see the size of these lenses inside the aperture of this lenses, this is 100x. Can you see how small the lens is when compared to other areas? So the scanner usually has the biggest aperture, whereas the 100 has the most less aperture. So the more power the lens has, the lesser the aperture the lens has. So what you do is, when you start to focus under the microscope, so what you do is you try to start with 4x, and that is very easy to focus. And then once you focus at 4x, you can just move around to 10x, you can just minimally adjust it, then go to 40x, and from there come to 100x. So don't start with 100x because it gets difficult for you to focus. Start with 4x and then eventually come to 100x. So now interpretation of the smear, once again, we'll see, we know that we have to study the morphology of the cells and what are the cells which exist in the peripheral smear, which are RBC, WBC, and platelets. Now, we'll talk about RBC first. So what we need to study in the morphology of RBC is, how is the size of the RBC? Is it normal? Is it increased or it is decreased? And how is the color? Is the color decreased or is the color normal? I'll talk about that just in a while. Now, what is the shape of an RBC? You all know that RBCs are biconcave shape. So that means the RBCs are like this. So this is one concavity and this is one concavity. Now you can see in the center of the RBC, the center of the RBC is very thin when compared to the periphery of the RBC. So the center of the RBC, can I say, has less hemoglobin when compared to the periphery of the RBC, which is filled with hemoglobin. So that is the reason why when we look it under the microscope, because in the microscope we add light from the bottom, the middle portion, this middle area which was the biconcavity, at that middle portion you have this central white thing and it is called as a central pallor. So the size of the RBC can be compared to some WBC, and this WBC is a small lymphocyte. So examiners also love to ask that what is the cell that you compare your RBC with. So the answer is normal RBC is about the same size as the nucleus of a small lymphocyte. So these are lymphocytes. Lymphocytes have a thin rim of cytoplasm, so these are lymphocytes, and the nucleus of the small lymphocyte is normally equal to the size of the normocytic RBC. So you have normal sized RBC, and this RBC size, when it is abnormal, it could be either microcytic, meaning it is smaller, or it could be either macrocytic, which means it could be bigger. So you have normal, microcytic, and macrocytic. So now, based on the color once again, we'll talk about few things as well here. So as I told you, in the middle there is one white space, and that space is called as the central pallor. Now normally the central pallor is about 1/3 or less than 1/3 of the RBC size, but for some reason if this size increases, then it is pathology. So now in normal you have something like this, and there is hypochromia wherein it is increased. The central pallor now is greater than 1/3, it is almost 2/3 in this case, so it is increased. Now what do you think? Do you think there will be a hyperchromic RBC? Think about this. Because does RBC have a nucleus? Does RBC have a mitochondria? The answer is no. And the reason why the answer is no is RBC has removed nucleus, RBC has removed mitochondria to have more space to fill as much hemoglobin as possible. So already at its normal state, hemoglobin in the RBC is at its maximum density. So you can't pack more RBC with hemoglobin, right? So you can't pack more hemoglobin into this RBC. So that is the reason why there is no hyperchromic. There is only normal and there is hyperchromic, but there is no hyperchromic. There are some conditions though in which the central pallor is lost. So can you think about such conditions? So the central pallor, as I told you earlier, was because of the biconcave shape of the RBC, and there are some conditions such as hereditary spherocytosis in which the central pallor is lost because the RBCs are round shape and they are not biconcave anymore. So moving on, we'll talk about anemia. So you know that anemia is decreased RBC mass. So whenever RBC mass is decreased, that is called as anemia. There are different types of anemias based on the size and color. So one type is called as normocytic normochromic anemia, wherein the RBC mass is reduced, but the RBC morphology is normocytic and normochromic. Then we have something called as microcytic hypochromic anemia, meaning the size of the RBC is small and the color of the RBC is also less. So this is called as microcytic hypochromic anemia. And then you also have macrocytic anemia. So we don't call anything as hyperchromic because, as I told you earlier, that there is no entity such as hyperchromic because the RBC is already operating at its maximum hemoglobin that it can hold. So some people like to call it macrocytic normochromic. You can write that as well, or you can just write it simply as macrocytic anemia, because the moment you write macrocytic anemia, it is understood that it is normochromic. We'll try to focus for the exam. For our college, we have macrocytic hypochromic and macrocytic anemia. So we'll try to focus on these things. So now right here we have a smear and we'll try to go through the smear and try to see. Now we have a small lymphocyte here and you can see the nucleus of the small lymphocyte, and when you compare this nucleus to the size of the RBC, what do you think? Do you think the RBC size is bigger than the nucleus of this lymphocyte or smaller than the nucleus of this lymphocyte? So obviously they look small when compared to the nucleus of the small lymphocyte. So the answer is microcytic. And what about the central pallor? The central pallor is normally 1/3 or less, but here definitely we can see a big central pallor, and this is why it is called as hypochromic. So the RBC size is small and the color is less, so that is why it is called as microcytic hypochromic anemia. And can you see this cell? And this cell is sometimes referred to as a pencil cell, which is an elongated kind of a cell which has an increased central pallor. And I'll just tell you where you see all these cells. So now, if someone asks you what are the causes of microcytic hypochromic anemia, you should be ready with that, because if you get a slide of microcytic hypochromic anemia, the examiner will definitely ask you what are the different types, what are the different reasons why you can get microcytic hypochromic anemia. Now, there's one simple way to remember all this. So let's think of hemoglobin. Now you know that hemoglobin is made up of heme and globin. Now what is heme made up of? If you're thinking it is iron and protoporphyrin, you're right. So the answer would be hemoglobin. When I put together the whole thing, it is iron plus porphyrin plus globin. So any of this, if iron is decreased, for example, the hemoglobin eventually will reduce. If the porphyrin is reduced, once again the hemoglobin will be reduced, and if the globin is reduced, even then the hemoglobin will be reduced. So if you can't really produce hemoglobin, hemoglobin is the building block of RBC. So if you don't have hemoglobin production, obviously the size of the RBC will be less because RBCs are made of hemoglobin. And the color of the RBC is also because of the hemoglobin. It is red in color. So when you have less hemoglobin, obviously the color of the RBC would also be lesser. So now we'll talk about the causes. So simply we just write this formula, that is hemoglobin is iron plus porphyrin plus globin, and we'll try to see all the different causes of iron, all the different causes of microcytic hypochromic anemia. Now, one thing, if iron is reduced, what do we call it? We call it iron deficiency anemia. So one cause of microcytic hypochromic anemia is iron deficiency anemia. Now what do we call if globin is reduced? If globin is reduced, we call it thalassemia. So globin chains, you have alpha chains, you have beta chains. So if alpha globin chains are reduced, that is alpha thalassemia. If beta globin chains are reduced, that is beta thalassemia. Now porphyrin's function is to bind iron to it. If you can't bind iron because of some defect with the porphyrin, this is called as sideroblastic anemia, wherein in these people you'll see a few cells called as sideroblasts in the bone marrow, which are not really binding iron, and as a result iron just accumulates around the nucleus, and these are called as ringed sideroblast, and the anemia is called as sideroblastic anemia. Now apart from these three, there is one more thing to remember, and that is anemia of chronic disease, which is kind of similar to iron deficiency, but these people will have more ferritin when compared to iron. So there are four causes once again. One is iron deficiency anemia, one is sideroblastic anemia, one is thalassemia, and the last one is anemia of chronic disease. Now moving on to macrocytic anemia. So we can see in the slide once again, there are small lymphocytes and there is the nucleus of the small lymphocyte. Now see this cell for example. Do you think the size of these cells are bigger than the nucleus of the small lymphocyte? Even this cell for example, they feel bigger than the nucleus of these small lymphocytes. So this answer is macrocytic anemia, wherein the cells are macrocytes and their size is bigger than the nucleus of the small lymphocyte. So what are the causes of macrocytic anemia? Once again, if you get macrocytic anemia, this question is coming to you, and the most common cause of macrocytic anemia is B12 and folate deficiency. Apart from these, you also have to remember that alcoholism also causes a macrocytic anemia, and then even conditions such as hypothyroidism will also cause a macrocytic anemia. So if someone asks you why are RBCs big in B12 and folate deficiency, the reason is, let's see the precursors of RBC. You know that RBCs, the erythrocytes, are produced from an erythroblast which is in the bone marrow, and the erythroblast actually contains a nucleus, right? So as it matures, eventually when it reaches the reticulocyte, the nucleus of the erythroblast is lost and then it becomes the reticulocyte, and after that it matures fully to become the erythrocyte. So one more thing is, see the size of the precursor. So which is bigger? Is the mature cell bigger or is the precursor bigger? So precursors are always bigger than the mature cells. So now let's imagine you don't have B12 or folate. What is the function of B12 and folate? The function of B12 and folate is to produce DNA, and because if DNA is produced, then only the nuclear maturation can happen. If the nucleus maturation cannot happen, by maturation I mean the nucleus is starting to shrink. So the shrinking doesn't happen. What happens is the precursor cells remain bigger, and eventually when you produce the RBC from that cell, the RBC is bigger. So you have bigger RBCs, but the number has been decreased. So that is the reason why you get anemia. So the reason why RBCs are big in B12 and folate deficiency is there is no proper nuclear maturation. So as a result, the nucleus are not maturing within the precursor cells, and as a result, when finally it matures, the erythrocyte still remains bigger. So now once again, there is one more cell to remember. So these are all macrocytes. Sometimes they're oval and they're called as macroovalocytes. So these things. And there is one neutrophil here and let's count the number of lobes in the neutrophil. Normally, you know that the lobes in the neutrophil are about 3 to 5, but in this, there are 1, 2, 3, 4, 5, 6 lobes. So what do we call this neutrophil? We call this neutrophil a hypersegmented neutrophil, which is also a feature of this macrocytic anemia, which is caused by B12 and folate. And the reason why is not only RBC precursors, but WBC precursors are also affected. So their nuclear maturation also takes time. So by the time a neutrophil is produced, there is much more nuclear material when compared to normal people's neutrophil, and as a result, you have hypersegmentation to accommodate all this DNA. So now in our WBC, we need to see what is the count of the WBC, etc. And we also need to see each type of WBC and how they are in relation to with each other. So now WBC, there are different types of WBC, you know all that. And there is a neutrophil, there is an eosinophil, there is a basophil, and all these three put together is called as are granulocytes. And you have lymphocyte and monocytes, which are the agranulocytes. So the first three are granulocytes, whereas the next two are the agranulocytes. So now here in this granulocytes and agranulocytes, we'll try to see the morphology of these cells. So number one is the neutrophil. So neutrophil has 3 lobes, 3 to 5 lobes. That is why some neutrophils have 3 lobes, some neutrophils have 4 lobes, some neutrophils have 5 lobes. So that is why sometimes they're referred to as polymorphonuclear cells. So right here it is the neutrophil. And now number 2 is a very beautiful looking cell which is containing 2 lobes, and this cell is called as the eosinophil. Now eosinophil, the thing which makes eosinophil different is that, see the granules when compared to the neutrophils, they have very distinct pink granules. So these granules represent that this is an eosinophil, And then we have a basophil. Let's not bother so much about the basophil because normal people, you don't see basophils. In the exam also, when you write the differential count, you write basophils as 0. But they have this thick granules when compared to eosinophil or neutrophil. They have fine granules, whereas this basophil will have very thick or coarse granules. So whereas in agranulocytosis, we already saw a lymphocyte. A lymphocyte has a tiny rim of cytoplasm, and eventually this is a monocyte, and monocyte has this characteristic bean-shaped nucleus. So if I ask you what are these cells, so right here, this is a neutrophil. This is also a neutrophil. Now right here, can you see the granules which are very different from these two neutrophils? So there are pink and there are 2 or 3 lobes, doesn't matter, but as long as the granules are very pink, this is an eosinophil. And right here, this is once again, they're all very coarse granules, etc. And this is a basophil. And right here, this is a lymphocyte which has a thin rim of cytoplasm. And here we have a bean-shaped nucleus and big cytoplasm, and this is a monocyte. So these are all the different types of WBC that we see in a peripheral smear. So now the normal values, the most abundant cell in the peripheral smear in an adult is neutrophil, followed by lymphocyte, followed by monocyte, followed by eosinophil, and followed by basophil. So if someone asks you, what is the normal WBC count? So there are two things here. So one is the normal WBC count is about 4,000 to 11,000 per cubic millimeter, and this is what we call the total leukocyte count. So we need to talk about the total leukocyte count, which is normally 4,000 to 11,000, and then we try to say what type of WBCs are these, right? So which percentage is neutrophil, which percentage is lymphocyte, which percentage is monocyte, and this is called as differential leukocyte count. So when we are checking WBC, we need to see how is the total leukocyte count and how is the differential leukocyte count. Is it normal or is it abnormal? Now this box, I think you're familiar with this box. Everyone gets this box on their answer sheet, and this box is called as differential leukocyte count box. Now first year you must have used this box, and you need to fill this box by writing the alphabet of the WBC. For example, if you see a neutrophil, you write N. If you see a leukocyte, you write an L. If you see a monocyte, you write an M. If you see eosinophil, you write an E. And if you see basophil, you write a B. But don't bother about basophils because basophils are usually 0 to 1%. So just write it as 0 and then you fill it with N, L, M, E. I've seen people writing even R sometimes inside it. It doesn't make any sense because this box is differential leukocyte count box. It is a leukocyte count box. So leukocytes, don't write erythrocytes here. Don't write R, which is RBC. And also, not that it, but I've once seen people, there was one guy who drew something like this. He drew some snakes and he told me that it is microfilaria that he have seen. So he doesn't know what to do, but that board looked very well and it was exactly looking like when we play snakes and ladders. So that's how that paper was looking. And we all were very happy seeing that, and we told to ourselves,
Wow, nice.
so don't make that mistake. When you write something in that box should only contain WBC. So whether it is neutrophil, monocyte, lymphocyte, basophil, or eosinophil, it should not contain RBC, or even worse, please don't draw anything inside that box. Now, there are few things to remember here while you're making that DLC box and writing these alphabets, is that you need to randomize as much as possible. That is, you don't want to be in the same area and you don't want to count the same area twice. So what we have is, here we have something called as methods for differential count. So when you put this microscope and when you put this slide under the microscope and try to see, you try to go through different methods so that you don't come to the same place again. So one method is called as Battleman method, wherein you go in a zigzag fashion and try to count the number of WBC and try to put them into the box. And there is one more method called as longitudinal strip, which is a different, it's just a longitudinal way. And then you eventually have the step technique, wherein you go from here like that, like that, like that, like that. So this is called as a step technique, and these things help you to randomize as much as possible and prevent you to come back to the same place that you have already counted. Now let's try to just for an example, let's try to draw these things. So number one here is that you have neutrophil, you have neutrophil, you have neutrophil. There are once again 4 lobes. This is a neutrophil. Here 5 lobes, it's a neutrophil. Once again 3 lobes, neutrophil, neutrophil, neutrophil. But see this one, it has 2 lobes and these granules are very pink. Now what do you think this cell is? This cell is an eosinophil. So how many neutrophils do we have in this field? 1, 2, 3, 4, 5, 6, 7, 8, whereas we have one eosinophil. So when I draw this, I can just write N, 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 and there is one E in the middle that I have written. Now, if I go to another place, now here we can see a bean-shaped thing. So what is this bean-shaped thing? It is an M. So what do we write here? We write it as M. And then eventually we have like this. And what do you see here? This is one lymphocyte. This is one lymphocyte. So now we are seeing two lymphocytes. So when I fill this box, I write it as L and L. So that is the lymphocyte. So I go across the slide. I go across all the parts in the slide and try to fill it till I get 100 is filled. So then eventually, let's say I've filled all my 100 boxes. Then what I do is I count how many N's I got. I'll count how many L's I got, how many M's I got, and eventually I'll write this little box. So which is, I'm trying to see how many are there. So I got in this box, I got 65% neutrophils, 30% lymphocytes, 2 eosinophils, and 3 monocytes. And one, please remember this thing is that when you draw this box and when you write these things, please make sure they all add up to 100. So 65 plus 30 is 95, 95 plus 2 is 97, and 97 plus 3 is 100. So I know a lot of people will just try to write whatever they want in that box, and what blunder they make is when they eventually add up, you'll get 104, 105, or some people get 95, 96. So it clearly tells the examiner that you have just written whatever you want. So sometimes you can fake it, but if you fake it, it has to be more better that you do it in the exam. So that is when you count everything, it has to be 100. So please make sure that when you draw this box and when you count this box, you get 100 cells, because this box is a 10 by 10 box which contains 100 boxes eventually. So now WBC, talking about WBC again. Now I told you there are two things to remember in the WBC. One is total leukocyte count and one is differential leukocyte count. Now can you tell me what do we call if the total count is increased? I told you before that the normal total count is 4,000 to 11,000. So what do we call if the total leukocyte count is greater than 11,000? It is called as leukocytosis. Now in the other way, what do we call if the total leukocyte count is decreased? It is called as leukopenia, or it is also called as leukocytopenia. So now in the differentials, you have different abnormals. We'll talk about things which increase these things. So number one is neutrophilia. Neutrophilia is caused by acute bacterial infections. You need to remember that neutrophils as such are the cells of acute inflammation. So they are the major cells which take part in acute inflammation. So neutrophilia is commonly seen with acute bacterial infections which generate a lot of systemic immune response. Now, lymphocytosis can be seen with viral infections because neutrophils don't really work on the viruses. Viruses are smaller and they are very good at evading our neutrophils. So you need lymphocytes to produce antibodies, etc., against the viral infections, or cell-mediated immunity against the viral infections, and also chronic infections as well, because note that lymphocyte is the cell of chronic infection. So people with chronic infections, a lymphocyte is increased. Now, one more thing is there is one good bacterial infection which causes lymphocytosis. Can you tell me what? So if you're thinking of the answer as pertussis, so there is a bacillus called as Bacillus botadella pertussis, which is a parasite, which is a bacteria which causes whooping cough. So this whooping cough is caused by pertussis, and this pertussis produces something called as a lymphocytosis promoting factor, and it produces something called as lymphocytosis. Now you also have eosinophilia. If you get an eosinophilia slide, they'll definitely ask you what are the causes of eosinophilia, and the answer is allergies. So people with asthma, allergic rhinitis, etc., will all have increased eosinophilia in their blood, and also very importantly, intestinal parasites. So there are some parasites in the intestine, for example, Ankylostoma duodenale, Enterobius vermicularis. So all these things will cause eosinophilia. Now monocytes, there is one common thing that people, not that common anymore nowadays, but there is one disease that people love to ask you, and that is Kala Azar, which is Leishmaniasis. So Leishmania donovani, that is the one which causes a disease called as Kala Azar, and in Kala Azar you see a lot of monocytosis, and also tuberculosis as well. In tuberculosis you see lymphocytes, but apart from lymphocytes you can also see monocytosis. So tuberculosis is a chronic bacterial infection. And lastly, basophilia, there is one thing that you need to know, and that is CML, which is chronic myelogenous leukemia. So lastly, about the platelets. So platelets, we just see the normal count, and the normal count is about 1.5 lakhs to 4 lakhs. So when we write about platelets in our report, we write it whether they are adequate or not. So if they are anywhere from 1.5 to 4 lakhs, we write them as adequate. But if they are less than that, we call it as thrombocytopenia. Don't bother about this because all the cases in our college don't have any platelet abnormality. But you know the causes which decrease platelet count. A very common example of this is a viral infection called dengue fever, wherein the platelet values are less. So if they ask you in the exam, you tell about these causes, but don't bother about platelets for now. So how we count whether they are adequate or not is we count 10 fields at 100x, and then we try to multiply the average with 20,000. So for example, if I just see this field, I have one, this is one platelet, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 12. So around 12 platelets I'm seeing. If I count, let's say 10 boxes, and if I got an average of 10, for example, I do 10 into 20,000 and I get 2 lakhs, and that is how I say that these are adequate. So this is not much important for the exam. No one would actually ask you about all these things, but I'm just putting it here. So now in the exam, we have the most important part right now. It is we have four things that we need to know for the exam, and one is microcytic hypochromic anemia. There are slides, so some of you will get this microcytic hypochromic anemia. Then some of you will get macrocytic anemia. Some of you will get neutrophilic leukocytosis, and some of you will get eosinophilia. So out of four slides, two have pathology in RBC, whereas two have pathology in the WBC, and there are no platelet abnormalities as I talked about earlier. So now, in the case of microcytic hypochromic anemia, you see under the microscope, etc., and you have diagnosed it as microcytic hypochromic anemia. What should you write in the exam paper? That is what we are trying to see. Now, we need to write about RBC, we need to write about WBC, we need to write about platelets, and we also need to write about hemoparasites. So previously I told you one of the examples of a hemoparasite is malaria. So we don't have malaria in any slide, but we just need to write that hemoparasites, and we need to write if did we see hemoparasites, yes or no. And eventually you have to write the impression. With the impression itself is microcytic hypochromic anemia. So let's see how we can write this report. Now RBC, I told you in RBC we have to write about the size of the RBC and the color of the RBC. So what is the size of the RBC and color of the RBC in microcytic hypochromic anemia? That is microcytic hypochromic RBC are seen. So the size is smaller and the color is lesser, so that is why it is microcytic hypochromic. Now in cases of microcytic hypochromic anemia, the slides that we have in our college, all the other things are normal. So WBC or normal. So what do we write is, once again in WBC I told you there are two parameters. One is the total leukocyte count and one is the differential leukocyte count. So you write total leukocyte count is within normal limits and differential leukocyte count is also within normal limits. Now platelets, again I told you that we talk about the number, so we write it as adequate because there is no platelet abnormality in our slides. And then hemoparasites, for example malaria, you write it as nil because there is no malaria in our slides. And eventually our impression, when you write the impression, it should be microcytic hypochromic anemia. So you start with microcytic hypochromic RBC and you end the impression as microcytic hypochromic anemia. And before you fill this all thing, you have to also fill the boxes, which I'll just talk about in a while, the DLC box, etc. So now let's talk about macrocytic anemia. So in macrocytic anemia, once again, we write about RBC, WBC, platelet and hemoparasite, and eventually we write about the impression. So what do we write in RBC? So once again, the size and color. So what is the size in macrocytic anemia? It is big. So you write macrocytic RBC. And what is the color of the RBC? Is it normocytic or is it is it normochromic or is it hypochromic or is it hyperchromic? So I told you before that there is no hyperchromic. So this would be macrocytic normochromic RBC, and you can write that there are few macroovalocytes which are seen. So it is an example of megaloblastic anemia. Do you see megaloblast in the peripheral smear? You don't see, because blasts are there in the bone marrow. So when you write about B12 and folate, even though they cause megaloblastic anemia, which is a form of macrocytic anemia, megaloblasts are seen in the bone marrow and not in the peripheral smear. Now what about the WBC? Once again, I told you once you have this, everything else is normal. So already RBC, the pathology we have finished. So in RBC also, in WBC also, you write two things. One is the total leukocyte count and one is the differential leukocyte count. So you have total leukocyte count is within normal limits and differential leukocyte count is also within the normal limits, and platelets are adequate and hemoparasites are nil, and the impression here is macrocytic anemia. So for both microcytic and macrocytic anemia, you write these things. But before that, you also need to fill this box. So just fill a normal box. For example, 65, 30, 2, 3. You change this. Just don't write these boxes, because I've seen people writing the same differential count which was there in the record. So everyone, 100 people in the batch, they all wrote the same differential count and they would write the same thing in the exam as well. So obviously, right, we don't have the same thing for all the different samples, but the idea is you write something related to that. You write some normal values if you get RBC pathology, because here WBC parameters are normal in this RBC pathology cases. Now moving on to the case number 3, which is neutrophilic leukocytosis. Now once again we write RBC, WBC, platelet and hemoparasite. So since there is no pathology with the RBC here, because we already know that the case is neutrophilic leukocytosis, what you write is RBCs are normocytic, normochromic. So RBC here would be normocytic and normochromic. Now what about WBC? So since I told it is leukocytosis, the total leukocyte count is increased. That is why we are calling it leukocytosis. Now what about neutrophilic? The differential count will show neutrophilia. So when I write this, I write it as total leukocyte count is increased and differential leukocyte count shows neutrophilia. Now once again, once we finish the pathology, everything else is nice. That is, platelets are adequate and hemoparasites are nil. So what is our impression? Our impression is neutrophilic leukocytosis. So when we write this differential count, I just put an example. So neutrophils are normally up to 70%, but here they are about 85%, and the lymphocytes are about 10%, 1% eosinophil, 4% monocytes, and the basophils are 0. So when I count this, I should get 100. So please check that again. 85 plus 10 is 95, 95 plus 1 is 96, and 96 plus 4 is 100. So I got my 100. And the box will look something like this. So please fill the box properly and fill only with WBC. Don't write anything else apart from the WBC in this box. So lastly, we'll talk about the case of eosinophilia. Once again, we write about RBC, WBC, platelets, hemoparasites, and impressions. So RBC here, again, it is normocytic, normochromic. Now the case that you have, I've just got an opportunity to see one of the case today, which is eosinophilia, and it is a very beautiful slide wherein the total count is actually increased and the differential count shows very marked eosinophilia. So technically this case should be eosinophilic leukocytosis because there are so much leukocytosis and there is a lot of eosinophilia, but okay, it's okay if you just write eosinophilia. So once we finish WBC pathology, everything else is normal. So platelets are adequate and hemoparasites are nil. So this impression is eosinophilia. So before writing all this report, you have to fill the box and you have to write the differential leukocyte count. So here in the case that we have, it's a very rare case wherein the eosinophils are very, very high. So the eosinophils are about 80%. So everyone don't write 80% as such. Just check your slide because there can be some variation in the slides that we have. So some people can write 70, some people can write more than that. And there are some cases, this time I don't know if they are put, but sometimes eosinophils, because up to 6% only is normal. Some cases can have only 10% or some cases can have only 20%. But the case I've seen, it has a classic 80% eosinophils. So you can write something like this, which is 10% neutrophils, 6% lymphocytes, 80% eosinophils, and 4% monocytes. And once you write this, you also need to count everything. So that is 10 plus 6 is 16, 16 plus 80 is 96, and 96 plus 4 is 100 to make sure that when you add up everything, you get a value of 100. So that would end the discussion of this peripheral smear. So just try to make sure that you go through everything and try to see the RBC, try to see the WBC, and try to see the platelets, and try to keep these 4 diagnoses in mind, which is microcytic hypochromic anemia, macrocytic anemia, neutrophilic leukocytosis, and eosinophilia. And out of these 4, I'm pretty sure if you look at the slides properly, you can come to the diagnosis and you could answer everything related to this thing and maximize the 10 marks that you have in this hematology slide. All right, good luck for the exams.